Hello, this is Dr. Amy Toone, and I'm going to be recording the musculoskeletal assessment system. And the musculoskeletal system provides the stability and mobility necessary for physical activity. It also protects organs. General principle, musculoskeletal is performed if there's a symptom, and therefore it's a little different from just a screening exam. It's one of those that tends to be focused on a symptomatic area. And I'm going to cover the ones that are most commonly performed in family practice for the general population. The big thing about musculoskeletal is the historical clues that you get for how they were injured and how the pain started, and was it single or multiple joints. And one of the biggest things you need to remember here is if a joint is injured, you must examine the joint above and below that joint in order to get a good thorough assessment. Second, you want to notice if it was an acute thing that happened, like with trauma, or was it something slow and progressive. And if there is an injury, what was the mechanism, meaning what part of the body was hurt and what position was the rest of the body in when it was hurt. Find out if there was any previous problems in the area, and you'll note that once there's been a major injury to the musculoskeletal system, often that area is more easily traumatized. And note if there's any symptomatic symptoms such as fever, a cough, like a cough that's gone on and now they're having rib pain, and they might have fractured a rib, or they might have fractured a vertebrae for continued coughing. So let's start about the physical exam. First, you're going to inspect the skeleton and extremities and compare sides for alignment, contours, symmetry, size, and any kind of gross deformities where it's not symmetrical. And understand normal functional anatomy is essential for this to happen. So you're going to start with the skin and subcutaneous tissues over the muscles and joints. Look for color, number of skin folds. And this is particularly important in the thigh section, anterior and posterior thighs, because the number of skin folds is often going to tell you if there's a problem with one leg being shorter or longer than the other leg. And the number of skin folds would be more on the leg that tends to be shorter. If there's any swelling or you feel any masses. And you realize that some joints that often swell, like for example the knee, there's not a lot of area for it to swell, so the knee will swell very rapidly, and it also decreases the edema rather rapidly because there's not a lot of area for that extra fluid to go to. Then you're going to notice and inspect the muscles and compare contralateral sides for size, symmetry, and fasciculations or spasms. Fasciculations often will be in the eyes or any kind of spasms that the muscles will have, and you can see that sometimes in the biceps, or you can see spasms in the leg occasionally. You're going to palpate all the bones, joints, and surrounding muscles for the following: muscle tone, and to see if the tone is equal bilaterally. See if there's any area that is excessive heat over the muscles, and that would make you think, particularly of, if it's in the legs, of clots, blood clots in the legs, phlebitis, that kind of thing. If there's any tenderness when you touch it, and then find if there's tenderness, think of the anatomy underneath. And is there tenderness when you touch the artery that you're pressing on, or is there tenderness when you clamp around the muscle? And that's particularly important on the popliteal artery or on the gastrocnemius muscle of the calf. Notice if there's any kind of swelling or any kind of crepitus. And you find crepitus often in the shoulders, neck, hips, knees, and ankles. You want to teach each major joint and test them, not teach each major joint, test each major joint for active and passive range of motion, realizing that active range of motion, will be about 5 to 10% less than your passive range of motion. You're able to push them a little bit more, and that margin between active and passive range of motion, with passive being a little bit more range of motion, is what physical therapy works on to try to get the active range of motion as much as the passive, or as close to it as they can. And you want to compare contralateral sides. You want to test the major muscle groups for strength and compare the contralateral sides. And then you want to look at neurovascular assessment at the same time, because as you're doing these assessments of the muscles, it's easy to just throw in palpating the pulses and going ahead and doing your reflexes. So the joints that deserve particular attention is the hands, wrist, elbows, shoulders, temporomandibular joint, cervical, thoracic, and lumbar spine, the hips, legs, and knees, feet and ankles. So you realize that anytime that you flex any joint and it comes closer to the heart, that's flexion. So if you flex your neck down, or if you flex your elbows up, it's all closer to the heart. You can flex your knees, you can flex your foot, and flexion is always basically going closer to the heart, and extension is going just the opposite, or away from the heart as much as you can. Abduction, ABD, is moving away from the body, and adduction is you're adding to the center of the body, or the median part of the body, and so as you move your arms down, that is abduction. So, realize that in the musculoskeletal system, you're going to look at ligaments, and realize that ligaments are attached by muscles by tendons, and they're cushioned by cartilage. So sometimes you're going to be looking at the cartilage also, or bursa is another way to say that. Major parts of the musculoskeletal system are bones, joints, ligaments. You connect bone to bone. You look at muscles, tendons, and realize that tendons connect muscle to bone. And so you would realize if tendons connect muscle to bone, they would have more laxity in them than a ligament would, because it's just bone to bone with one connective tissue. So that's why if you pull a ligament, it's much harder to heal. Or if you tear a ligament, those are harder to heal than if you do a tendon, because your muscle will give, and the muscle might be bruised, but it's got a lot of give in it compared to just bone to bone. And then you also need to look at the cartilage. Now, the musculoskeletal system functions, you want to give structure to the soft tissues, and you also realize that the musculoskeletal system gives movement to the body, protects your vital organs, the heart, lungs, and liver, spleen, stomach are all protected, kidneys. So most of your organs outside of your gut are going in, and in the pelvis, they're in the pelvic floor, so they've got the pelvic area protecting the pelvic bones. So it's just your gut is actually not as protected. Realize musculoskeletal system produces the blood cells for hematopoiesis, and it has a point of reabsorption and reformation with osteoblastic and osteoclastic activity, like you studied in patho. And if you remember that osteoblast will build will build bone, and osteoclastic is what cleans and seals new bone growth. Joint types. There's a couple of types of joint types, and you have some joint types that have no movement, and that would be like your cranial sutures. And you have some joints that move between the epiphysis and the diaphysis of the long bones. And you've got some bones that are slightly movable, like your pubic symphysis. And the biggest part of that, when it moves, is usually when the pelvic floor needs to move due to carrying a baby. And then you've got synovial or freely movable ball and socket joints, like your hip. You got a hinge joint on your elbow and a pivotal joints on the adaxial joints. And you've got several different types of joints, but most of them are meant to move in certain ways, but only certain ways. Here's a summation of all this. You do have a few gliding joints, that your intervertebral joints, that are needed to move so your back can move. Okay, and as you look at the different types of joints, you realize that on the diarthral joints, you've got a fibrous capsule and cartilage and ligaments. There's also synovial membrane, synovial fluid, which gives you lubrication, and the bursa, which promotes the ease of motion at points where friction would otherwise occur. And the bursa is an oil-filled sac that is meant to just be an extra cushion. Muscles, they're affected by genetics, exercise, and nutrition. And muscles should move through a normal range of motion. Upper extremities, the shoulder, elbow, forearm, wrist, and hand on the upper extremities. And then on the head, you've got your temporomandibular joint, the spine that starts at the cervical, thoracic, and then the lumbar and the sacral vertebrae going towards the bottom. Your lower extremities is the hip, knee, ankle, and foot. And for infants and children, realize long bones increase in length and thickness throughout childhood. Cartilage in smaller bones ossifies, and ligaments are stronger than bones until adolescence, and fractures are very common. That's the nice thing about the ligaments. As they are stronger than bones, it will allow the bone to break and the bone could re-heal. And that's why if a bone breaks on a child and the ligaments hang in there and don't break, then you're usually going to have better healing with less complications than if you have ligaments that totally tear on them. Muscle fibers will lengthen as the children grow, and the skeletal systems will grow. On an infant, you want to sit them up and palpate the spine. Look for the shape, formation, and splitting. You want to palpate on the spine to feel any dimpling along the vertebrae processes. And you want to palpate the muscles and joints for tone, mobility, and if there's any subluxation or dislocation. We're going to go into that in a while so you'll know what is the common subluxation and dislocation. Okay, infants, you want to assess the motor development with fine and gross. You want to assess the range of motion and assess muscle strength. And there's limits in your book that will tell you what would be the normal muscle strength of an infant at what age, and when they're going to have head lag, when they're able to pull themselves up, when they're able to walk holding on to furniture. That's outlined in your book. And then you want to assess for tibial torsion, which is common in some toddlers. The Barlow's Ortolani maneuvers detect hip location, or subluxation should be performed each time you examine the infant during the first year of life. And so here you're seeing the procedure in A. The first thing you're going to do is, phase A is you're going to do abduction, and then where you have both knees up and you flex it up, and then you're going to do Abduction is where you have the knees together, and abduction is where you spread them apart. And you're going to feel if you have how I placed my hands versus this first picture is on the knees. I placed my hands where my thumbs are on the knees and my fingers are under the hips. And then that way, when I push and flex the knees up, I can feel a pop by my fingers that are underneath the hip. And then I will spread the legs or abduct them to see if there's any asymmetry in the gluteal folds. Like you see on this gluteal fold to the patient's right, it seems to be a little different than what you see on the left. And on the left you see 2 gluteal folds, and on the right you only see 1. And the Barlow's manner, position yourself at the supine infant's feet, flex the hip up, grab the legs, and I just said how I do it. I put my thumbs on the knees and your outer fingers gripping the outer thighs. An abduct, positive sign is when you feel a slipping or clunk sensation is felt on the femoral head and exits the acetabular posteriorly. Okay, and here's your ortolani's, and we've just discussed that. Okay, on children, you need to assess the motor development, fine and gross, assess the range of motions, and curvature of the spine. What is their normal sitting posture? Do they sit crisscross legs? Are they able to sit with their legs straight out? Do they have a foot arch? Is there an alignment of the feet and legs? And you, on an older child that's able to walk, you look at the posture and gait, symmetries and tiptoes. Can they walk on their toes and their heels, or do they actually tend to walk on their tiptoes or heels? And if you look at your Denver Developmental, that is in the back of your book, your Denver Developmental test will tell you what would be a normal musculoskeletal for gross musculoskeletal, and also fine touch on musculoskeletal for each assorted age group from 0 until 5 years old. You want to see if they're able to duck walk 4 steps on a child that's able to squat down like a duck and then walk in that squatted position, and that's called a duck walk. And you want to see if they're able to at least go 4 steps. When I do this on my school physicals or sports physicals, you have to have them walk across the room, not just 1 or 2 steps, but you want to see them walk all the way across the room. And if I'm doing a sports team, I will make them walk the width of the gym, not the length of the gym, but the width of the gym. And they're going to have to walk as a team, and that's going to let me see particularly which, and these are usually teenagers or tweens, but which ones are able to do it and have a loose back, lumbar area, because that's necessary. And duck walking will assess the musculoskeletal strength from the waist down. So it's one easy way to do strength and flexibility and one swooping assessment of a duck walk. You're also going to look at the shoulder and the clavicle for any kind of dislocations. Realize genu varum is bow leg and genu valgum is knock knee. And there's a lot of ways to remember it, but how I remember it is genu, V-A-R, is like an arrogant cowboy. I use the A-R for arrogant cowboy, and they're bow-legged. And valgum, you remember you put a piece of gum and keep your knees together. And so that's how I remember it. Valgum is knock knee because you got the gum to keep the knees together. It's kind of silly, but it's how I remember it. Okay, you want to find out if there's any in-toeing, and that means that there's a tibial torsion or curvature of the tibia caused by fetal positioning, This tends to resolve in about 16 months. Sometimes it's out to 18 months, but you want to monitor it. You also want to monitor if there's any metatarsus abductus or vargus is common, and it's foot deformity that can be fixed or flexible, and you want to find out, are they bow-legged. And some people are sure that this is from walking their child too early, but it's not always the case. But not leaving them on their feet all the time will help. Children tend to sit down whenever they want to sit down. And then femoral anteversion, or twist between the knee and the hip, and femoral twist medially or towards the middle. And this is the sitting W position. And the sitting W position will make the femoral anteversion worse. So you want to get them to not sit like a W, where they're sitting down and they've got both legs out and their legs kind of look like a W. Evaluation for genivarum is normal until 18 months. Measure the distance between the knees on the medial malleola of the ankles are together. If present, there's a 2.5 centimeter space. Knock knees is normal until 2 to 4 years old. Measure the distance between the medial malleola of the ankles and the knees together if present. If the space is 2.5 centimeters exist. And what are you going to do about either one of these? You can refer the child to an orthopedic person and see if they can do anything regarding braces. And the other thing is Scottish Rite Hospital works with all kinds of orthopedic problems. And so they're really good at screening and helping the children, and they do braces, shoes, everything the child would need up until age 18 to help them to be more mobile. Be sure and palpate the bones, muscles, joints, and you evaluate the patient as they rise from a seated position to see if they've got the Gower sign, and I'm going to show you Gower sign in a minute. The Gower sign basically is where they don't stand up, they rather walk getting from a seated position, they kind of walk up their legs because they don't have enough muscle strength to stand up without having to walk up their legs a little bit with their hands to stand up erect. And here you've got valgum or knock-knee in a young child. Notice that the knees are together a lot more than the ankles. And this young child that's sitting just in a relaxed, standing in a relaxed position. Adolescence. Adolescents have rapid growth in puberty, and it results in decreased strength of the epiphysis. And that gives them an increased risk for injury. And the oxymoron of this is, while the muscles and the bones are growing, you have to realize that there's hormones that affect the muscle and the bones, and testosterone is one of them. And so that's one of the reasons why the teenagers will grow very long, very fast in certain years as testosterone peaks. And also you're going to have growth hormone that will peak, and the growth hormone will dump out into the body, and that causes the bones to get longer. And when the growth hormone dumps out in the body, that's when the appetite increases a lot. So this is why adolescents are kind of known for they'll be eating normal, and then they'll just be hungry and they'll just eat the entire refrigerator, and then within a month they squirt up an inch, they grow an inch or 2 inches after they've had this big appetite. This also happens in toddlers, and they'll eat, and then once they grow taller, they don't eat so much. And then when the growth hormone kicks in, again, they start to eat and then they get taller. So it's one of those things that they eat before they tend to get taller. And after they get taller, there's a month to 3 months that a lot of the toddlers to adolescents don't eat so much. Okay, so that's puberty, growth hormone, and why they eat a lot when growth hormone goes up, and then they get taller and they tend not to eat so much. Realize that bone growth is completed by about age 20, but bone peak mass is achieved at age 35. So prior to that, you need to keep having calcium and vitamin D to keep your bone mass up, and also weight-bearing exercises. But it can be age 20, that's well past when girls start having their periods, and well past puberty in boys that the bone growth can occur. Adolescents do the same examination procedures as for the adults. You're going to note any presence of scoliosis in adolescents by bending them over and looking at their back, but you have to keep your eye level at their back level. And what that means is you have to bend over as they're bending over. You're going to note slight scoliosis, and this one is quite gross scoliosis, but you see that there's one side of her back that is much higher than the other. And if you have this child stand up, you see there's quite a scoliosis. If it's less than 10 degrees, they're not going to do much, but you can see that her clavicles are not even close on this child. And the first thing I notice when I do a back exam is I look at the two shoulders to see if they're symmetrical. Then I feel the scapula to see if they're symmetrical. This will be my first clue that there's a problem here. And then I feel the iliac crest, and this iliac crest is lower than this one over here, but you have to feel it. Her gluteal folds are equal on both sides. Okay. If it's greater than a 10-degree curve, you're going to refer them to see if they want to do anything in orthopedics. And you can see this shoulder is higher than this shoulder. And usually the shoulder of the predominant hand will be a little lower than the non-predominant hand. What do you do about pregnant women? You realize that there's increased mobility of the pelvic joints, and that's the effect of hormones, estrogen, progesterone. And there's progressive lordosis of the spine. It has to be because of the enlarged uterus. Lower back pain and muscle cramps are common for them. And you have to realize that they call it the pregnant waddle with the lordosis is going to be worse right before delivery. And the pubic symphysis can have pain because it's continuing to elongate prior to birth. Older adults have loss of bone density. They're at risk for fractures. And I'll give you a note about hips on older adults. Often when an older adult is walking down the hall or walking somewhere and they have a fracture of the hip, and this would be at the femoral head, they're going to fall. They're not able to put weight on that right side. Throws them off balance. I'm going to say that the right hip fractures, okay? They're not able to put any weight on that right leg because the hip fractured. They tend to fall to the left on the other hip. They tend not to fall on the side that they've actually fractured. And the reason for that is because if it's been a break and they're standing up and there's a break of the femoral head, they're going to throw their weight to the other side so much that they often get off balance, falling on the opposite side. And in this case, that would be the patient's left side. They hit on their left side. My point in saying that is to please assess both hips if you think that you've got a hip issue in an older adult. because you're going to notice that one side might be bruised. The other side is extremely painful. You got the fracture on the opposite side. Now, this does not, if there's a slip and fall where they slip and they fall on one side, that's a whole nother ball game. But if they say, I'm just walking down the hall, the next thing I know is I felt a pop in my right side and I felt in my left. That is real common. Older adults will fall forward, they'll fall to their side, but they tend not to fall back and hit the back occipital area of their head. And I mention that because if you've got an occipital area trauma, you have to rule out that somebody pushed them. The only thing is if they say, I'm going up the stairs and I missed the stairs and I fell back, that would be an exception. But in general, people tend not to fall backwards. And just think of a toddler. When they fall sideways and they fall back. But they fall forward, they fall down, but they don't fall back and hit the back of their head unless they've been pushed or it was falling off of a bike or something like that. But 9 times out of 10, when you fall, the injury to the head should be on the frontal bone and on the sides, but it shouldn't be in the occipital area. Okay, back to older adults. I chased a rabbit. But back to older adults, deterioration of joint cartilages, so that causes a decreased mobility. There's muscle mass decreases, and that causes muscle tone and strength decrease, reaction time and speed will decrease, and endurance will decrease. And sedentary lifestyle will cause degeneration of the musculoskeletal system, decreases flexibility a lot, and osteoporosis risk. You're going to notice that people that will exercise, even though obese, will have a lot more flexibility and a lot more stability in their movements, regardless of their weight. Abnormalities, ankylosing spondylitis is hereditary chronic inflammatory disease. Initially affects the lumbar spine and sacroiliac joints, and it is where the joints do not align exactly, one on top of the other. Lumbosacral radiculopathy is herniated lumbar disc that irritates the corresponding nerve root. Lumbar stenosis is hypertrophy of the ligament and facet joints that result in narrowing of the spinal canal. And so here you've got gross postural changes and affected by ankylosing spondylitis. And you realize that this patient here has kyphosis. He has no lumbar curvature of his spine at all. And he's got where you can't see his back in this picture, but you're going to realize that there might be some variations as you palpate down the spine, where they're not all aligned equally. So let's talk about the history, because this is the biggest thing you're going to have to do in musculoskeletal assessment. You're going to have to look at the history of the present illness and look at the joints for character-associated events like trauma, temporal factors, and for example, temporal factors is if there was something that the patient was overstressing their joint, they had to move that weekend, so their back and all their biceps and triceps, everything got overused over time. There wasn't a period of rest. If there's any efforts to treat and were they successful, look at the medications, NSAIDs, Tylenol, biological modifiers, and other immune suppressants. See if there's any corticosteroids, because that will decrease the inflammation. Any topical analgesics, glucosamine, chondroitin, or hyaluronic acid that they take to try to increase joint flexibility and health. Also, you're going to look at the muscular symptoms, comparing side to side for character, precipitating factors, again, effort to treat, and medications. Now, in the muscular symptoms, you're going to look at muscle relaxants. If they take any of those, any of the glycosides or aspirins, or any NSAIDs. Look at the skeletal system for character-associated events, efforts to treat, and at this skeletal system, you want to look at hormone therapies that they're on. Particularly, do they take any calcium, calcitonin, or biophosphates, things for thinning of the bones. You want to look at the injury. The big thing about the injury is, where was your joint and how did you get hit? Because on joints that have got ligaments in it, you tend to get hurt on the opposite side of the ligament of which you got hit. For example, the knees. If you get hit on the anterior part of the knees, like a baseball catcher, and somebody slides into that person, they're going to blow out their posterior cruciate ligament. Although the injury, they hit them on the anterior, the brunt of the blow comes out the posterior. If they get hit on and you have to have the ankles stationary, like playing football and somebody tackles ankles, and then somebody hits the knees. And if they do that, then all the force of the blow is going to go from the posterior to the anterior area because they got hit in the back. So if they got hit in the back of the legs, it's going to be the anterior cruciate ligament that blows or is injured. Okay, the same thing on the lateral side. If you get hit on the lateral side, it's going to be the medial cruciate ligament, and vice versa. If you get hit in the middle part of the knee or the medial side of the knee, it's going to be your lateral cruciate ligament that's going to have the brunt of the blow to it. So you want to find out what area got hit and what were they doing at the time. Were their knees stationary? That kind of stuff. Was the foot planted? Did somebody get on the top and the bottom of them? You also want to know, what was the sensation at the time of the injury? Did they say it popped? It clicked? I heard a snap? Those are all important indicators to let you know. I've already talked about mechanism of injury. What kind of pain did they have? Was there any swellings? Did they elevate it, put ice on it, rest it? And were they able to walk? There's Ottawa rules for when to x-ray, and we'll talk about this later in your curriculum, but it's, were they able to walk right after the injury, and if so, how many steps? Significant number you want to know is, were they able to walk on their own 4 to 10 feet? Which tends to be 4 to 10 steps. Actually, 4 to 10 feet might be about half those steps, but you want to try to get 4 to 10 steps out of them, and were they able to walk on that without assistance. Back pain. Find out if it was abrupt or gradual onset, the character of the pain and sensation, if there was any associated events and efforts to treat, and what kind of muscle relaxants, analgesics, or anti-inflammatory drugs did they take. You also want to note the trauma, the nerves, soft tissues, bones, joints, and any kind of residual problems that they might have from previous injuries, and any kind of bone infections they have, like if they've got diabetes and they've got a big infection that's gone all the way down to their bone. You want to know that. And if they've got osteomyelitis, that kind of thing. If they've had surgery on the bone, if there's been any kind of arthroscopic examinations, or scoping a knee is a real common one, amputations, any chronic illnesses, because some of the chronic illnesses, particularly of the gut, will change how much vitamin D will be absorbed. And so you want to know also if they've got chronic illnesses where they're not getting out in the sun much and they're not able to change the vitamin D from the sun. So you just want to know what else they've got going on. Any kind of skeletal deformities and congenital abnormalities. And the big thing on the skeletal deformities is you've got to look at that entire joint, all sides of it, because often you have a skeletal deformity, and in that deformity, it will affect other parts of the body. Family history, look to see if there's any congenital abnormalities of the hip and the foot. Scoliosis and back problems, arthritis, any genetic orders, whether it's osteogenesis imperfecta, skeletal dysplasia, rickets, hypophosphatemia, and hypercalciuria. One of the other things I ask in musculoskeletal is to see if there's any neural tube defects. And the easiest way to ask that question is to ask them, has anybody in your family not been able to walk normal? And that's the quickest way to look at that, because that's going to affect how you want to treat anybody else in that family that might be getting pregnant, and folic acid specifically. Okay, personal and social history, look at employment, exercise, if they've got weight-bearing exercises, functional ability, their height and weight changes, and any kind of nutrition that they have. Do they have adequate protein and calcium? And you want to know about tobacco and alcohol use, because tobacco is, both of these are going to be against full development of the musculoskeletal system. And the alcohol use and tobacco, one of the biggest things is you often have assorted malnutritions with them. On alcohol use, you're going to have problems absorbing some nutrients in the gut. And the other thing about alcohol use, if it gets to be excessive, then people will choose alcohol over a more nutritious meal. And with a lot of alcohol use, there's not a lot of exercise, and it can get to the point to where it impedes employment. On tobacco, the biggest thing about tobacco is if you can't breathe, and then it's very hard to do the exercise. So that's why you really want to know about tobacco and how much are they able to do the exercise without having coughing and changing and problems. The more they smoke, the less people exercise. It's the bottom line. Infants and kids, look at the birth history, the presentation, were they large or small for gestational age? Do they use forceps? And if there's any fine or gross motor developmental milestones that were inappropriate or appropriate for the chronological age, easiest way to test for this is look at your Denver developmental screening tool and follow that. Okay, kids and infants, you also want to look at overweight and obese, at what's the quality of movement, spasticity, and if there's any flaccidity, if they're spastic or flastic. And what that means is spastic is where there's a general shake, and flaccid is they're floppy. Instead of the normal tone, they're kind of floppy and overly loose. Loose to the point of floppy. If there's any cogwheel rigidity, and that's where you try to bring up the elbow, and as you try to push it down against resistance, does it just go down smooth when you can overpower it, or is it more like a cog, and it kind of catches like a gear on a wheel? That's what cogwheel is. Arm or leg pain, what's the character, onset, participation in organized or competitive sports, and weightlifting. And weightlifting is a great thing, but you can lift too much that the body can't tolerate, and it's going to affect the joints more than anything, not the muscles, but the joints. And there's a lot of people that will do weightlifting and build a very nice body, but they're going to overstress the knees by doing these multiple squats and deadlifts. And over time, it's going to wear out the joints. Pregnant women look for muscle cramps, back pain, weeks gestation, associated symptoms, and they're listed there. And why do you care about nausea and vomiting? Because you can get very low sodium and potassium from that, and that's going to cause some of your muscle cramps. Okay, fever, malaise, and with the fever and malaise, you want to find out if it's a high grade or a low grade fever and how long the malaise has been. And if the fever is cyclic or periodic, or has it been just a low grade fever all the time and you have to control it for a long time with some kind of anti-fever medicine. And you want to look at the type of shoes, and you want to look at, with these type of shoes, are the shoes equally worn out on the soles, and realize that high heels can increase lordosis. Older adults, look for weakness. When was the onset of weakness? Associated symptoms. And for example, if somebody's had to have 3 weeks of bed rest or 3 weeks of rest following a major surgery, they're going to be weak afterwards. And it's going to take them usually twice as long as it got weak to get strong again. So if it was 3 weeks that they had a period of rest and they noticed that their upper body strength is not what it used to be, it's going to take twice as long, like 6 weeks, to get that back. The problem is with a lot of these people in the older adults, it's the knees and the hips. And there are some people that will walk around for years with bad knees and hips and barely move. And then they have the surgery and they want to know why it didn't just get them back in the condition that they were. Well, it fixed the joint, but they've totally lost all the muscle tone. So this is why it's important for them to do the rehab and realize why it may take longer. But to do the rehab, you can keep a joint stronger by keeping the muscles that attach to the joint as strong as possible. And that will give the joint more stability. You also want to look in the older adult about increases in minor injuries, any change in the ease of movement, like getting up from the chair, any nocturnal muscle spasms. And if they're having that, are they on their legs? Are they in their feet? Any history of injuries or excessive use of a joint or group of joints? If they have any kind of claudication or known joint abnormalities or any previous fractures. And I'll talk just briefly about feet cramping with sleeping, because that's real common. And often that might be magnesium that is low. The other thing is as you go to sleep, your circulation, your heart rate goes down, the circulation goes down. These might be people that need to sleep in some socks. And to keep the feet warm, because once they get cold, a lot of times they're cramped. So if you've got a lot of foot cramping, get some thicker socks or regular, not so thick socks, and see if that helps. And if not, you can get some thicker socks. See if it's something simple like that. And if not, then you're going to have to look at the electrolytes and magnesium, which tends not to be on a chemistry panel. You have to order that separately. Okay, so what do you do for an examination? You look for a marking pencil, a going meter, tape measure, and a reflex hammer. And you're going to look for the posture for erectness, symmetry, and alignment. And the skin and subcutaneous tissues for swelling, redness, and masses. And then you're going to inspect the extremities for size, deformities, enlargements, alignment, contour, and symmetry. Look at the muscles for bilateral symmetry, hypertrophy, atrophy, any fasciculations and spasms. You're going to palpate the bones in the joints, and we named these previously. I'm trying to present this just in a very systematic fashion, so I repeated this slide. The range of motion, see if it's active or passive, and you're going to note the pain, limitations, joint instability, deformity, or contractions. And look at the range of motion. The range of motion, passive range of motion may exceed the active range of motion by 5 and sometimes 10 degrees on somebody that's been injured. And I mentioned before that this is where the physical therapy comes in, trying to get the active and the passive range of motions closer together. And if there's any kind of discrepancy, you look at muscle weakness or disorders, and you can do gonometer is where it's increased or decreased range of motion. And I'm going to show you that in a minute. Here's what you look for in muscle strength, and compare side to side or contralateral is the other way to say side to side, right-sided and left-sided. Okay, muscle strength, grade 0 is no voluntary contraction to 5, full muscle strength. Weakness can result from disuse, atrophy, pain, fever, or overstretching. And then the muscle strength, each muscle group is tested for their ability to resist. Like 5 is full resistance, 4 minimal resistance, 3 no resistance, but they can rise. 2 can't rise but can move, and 1 is no muscle strength whatsoever. Looking at the hands and the wrists, there's common abnormalities of the newborn's hand, and I'd like to talk to you about a simian crease that's in picture A that goes all the way across the hand. They tend not to go all the way across, but you find that some on simian's hands. The second one is when you've got some fingers that are joined, and the fourth one is polydactyly, is where they've got an extra finger. Realize that the fingers, the point of this picture is to show you the DIJ, our distal interphalangeal joint, is the farthest one. Proximal interphalangeal joint is the middle one, and the metacarpophalangeal joint, or it's called the MCP, is on the one over the knuckles. Okay, and then you've got the joints of the hand. And so here's telling you what bones to, just to remind you what bones to, and what joints to call what bones. It's just general anatomy. The features of the palmar aspect of the hand. The big thing about the hand is if you put your hand up and you extend your fingers, that means you point them away. If you're looking at your palm, extend your fingers and point them away from your heart. On everybody, you're going to notice that your creases get darker, and it should on all races. The creases get darker. A white person, they get red. On a black person, they get darker black. And on a brown person, they get a little darker brown. And that's typical for somebody that's not anemic. What you worry about is when you do that and you hyperextend your fingers and there's no change in the palmar creases, then you think this person is anemic. The other thing is sometimes along these palmar creases you can have little yellow streaks, and that's somebody that's got a bad disorder. And so they're going to have xanthelasma around the eyes and everything else by that point. Okay, you want to look at the hands and wrists for contour, position. What's their normal position that they're in? Are they got full range of motion, shape, number, and completeness of digits? You want to look at their finger deviation. The hands and wrists, you're going to palpate the joints for texture, swelling, tenderness, bogginess, nodules, and bone overgrowths. And on the hands and wrists, you're going to look at several procedures to look at the integrity of the median nerve. And that will be with Toonne's and feeling sign. I'll show you that in a minute. Certain patterns of pain, numbness, and tingling are associated with carpal tunnel. So the feeling test. The patient holds both wrists in a fully palmar flexed position with the dorsal surface pressed together for about 1 minute. And the numbness and tingling of the distribution of the medial nerve are suggestive of carpal tunnel. So in this picture, you're going to look at picture, they've got these pictures numbered wrong, but really B is the feelings test. And feeling, Phalin, Phalen's test. The Phelan test starts with a P, and I remember it's a funny way to pray. So I put the two P's together, prayer and Phelan's test. And Toone's test is where you're going to go ahead and extend your wrist, and you're going to tap on the median nerve where it has there, and you're going to have pain. And the pain, this is a picture in your book, but you've got the classic pain pattern, and in your book you've got pain and numbness, and it's a better picture that's in your book, but you can see it a little better. And so you're going to have the numbness, but you can look in your book and see what colors for the numbness and the tingling. On the hands and the wrist, realize that you're going to look at the contour, the shape, and if you're going to have any deformities of the fingers. And I want to tell you that there are some common deformities of the fingers that you need to remember. One is Bouchard's nodules, and it's on the IP joints, on the proximal IP joints, and I've got an arrow to it. And the Heberdines are the same description, but they're loaded over the distal IP joints. And what these two go with is Heberdines nodules goes with osteoarthritis. That's important to remember. Okay, so osteoarthritis, you're going to look at the Heberdines is real common with osteoarthritis. And let's see. You can also have the Swan-Ganz or Boutonniere's deformity in rheumatoid arthritis. And the ulnar deviations and subluxation in the MCP joints are often in rheumatoid arthritis. Bouchard's nodules and Heberdines nodules are more common in osteoarthritis. All right, this is how you're going to palpate the joints of the wrist and of the hand. Hands and wrist, you want to assess the range of motion, the flexions of the fingers. Expect 90 degrees, hyperextension of the fingers 30 degrees, and flexion of the wrist 90, and hyperextension of the wrist is around 70. The rotation of the hand, they should be able to rotate it around and look at the muscle strength bilaterally. Okay, so here it is, and picture A is flexion, and it's telling you the hyperextension that you would do. And this would be the normal movements you'd expect in the hand. Okay. And here you've got this is just another picture of B, the Heberdines nodules and the DIP joints, Bouchard's nodules. Okay. And I do want to talk about you've got this spindle shape enlargements of the proximal interphalangeal joints that you see in this picture A. So these are common deformities of the hand. Okay, on rheumatoid arthritis, which is the top picture, you have what's called an ulnar deviation. And what happens is all the fingers kind of deviate over towards the ulnar versus the radial head. And you can also have Swan-Ganz deformity, which is in picture B. And what you're looking at is from the fingernail going back towards the knuckle. It seems like it's got a little Swan-Ganz, or a neck of a swan on it. And C is Boutonniere's deformity, and we've already talked about this one time, but this was just another picture to show you. Okay, so what you want to do is thumb adduction test. You look at the strength of the adductor thumb by only pushing on the thumb with your thumb and seeing if they're going to be able to push against you well. Toonne's sign is striking I showed you a picture of Tonell's where you strike the median nerve, and you're looking for carpal tunnel syndrome at that point. With the Tonell sign, it's a tapping of the nerve, and it has the tingling sensation. Let's look at the elbow. The elbow is a hinge joint, and so the humerus is on top. You got the ulna on the right and the radius on the left. And the big thing about this is you realize that it's a hinge joint, so the cranion head of the ulna is possible to slip out. And this is what happens sometimes when somebody will pick up a toddler by just one arm and put them in the car, and they're just grab that elbow and they will pop the elbow out, and you'll learn how to pop that back in. Elbows, you want to look at the contour. The carrying angle is when they're just walking, what angle do they carry it at? Is it straight, or do they have to flex it 45 degrees? You want to look for any subcutaneous nodules, palpate for tenderness and thickening. And here's the normal expectations. So here it is again. And when you would expect this, how much you would expect the elbow to be able to move. I want to talk about pronation and supination and how you can remember that. If you put your two hands together like you're saying a prayer, and you've got your two palms together, and then roll them out to where it's like a bowl, that's supination. And so when you roll it out like a bowl, think of a soup bowl. That's supination. Pronation is when you have your hands flat on a desk. And just like if you lie prone, you got your abdomen flat on a desk. Here's how you go ahead and measure the range of motion. Most nurse practitioners and advanced practice nurses tend not to do this. You're sending them to physical therapy to do all those measurements, because physical therapy is working in that 5 to 10% margin between active and passive range of motion. Okay, evaluation of the muscle strength and how you can do that. There's on the elbow, there's a real common thing, and it's called olecranium bursitis. The other word for this is truck driver's elbow. And it's from always grabbing, sitting, and people do it in desk chairs where they always push up on their elbow, and over time you've got a bursa there at the end of the elbow to make sure that you don't have any kind of trauma to your elbow. And you've inflamed the bursa here. And the trick to this is you can just stick a needle in there and suck that out. But you have to wrap it tight with an ACE, so it will re-inflame just as quick. Put a lot of ice on it. But this is why it's happened, is this is somebody that's leaned, and it tends to be their non-predominant hand, and they're lean on that side and lean on their elbow, and the elbow's not meant to be a weight-bearing joint. Let's talk about the shoulder. You've got the supraspinatus muscle, you've got the infraspinatus, and you've got the teres minor muscle. You realize that a shoulder is twice as hard to rehab as a knee because it's got so many different ways that it can move. I'm going to give you another picture, and instead of just looking at the muscles, here we're going to look at the bursa. And you've got your subacromial bursa here. You also have got another bursa with your subdeltoid bursa. And this is to prevent trauma from down on your shoulder and from something hitting. It's to pad your humerus, the head of the humerus. And the other thing that you realize is you got your supraspinatus muscle that's coming from the back and attaching way over here on your greater tubercle of the humerus. Shoulders, you look at size symmetry, and on the shoulders you want to see if there's any dislocating or winging of the scapula. And winging means you should palpate both scapula and they should be flat. Have the patient do like a push-up against the wall and stop halfway there with their arms flexed in a push-up position against a wall. Or some people say assume the position of a rest, where you put your hands against the wall. You want to feel the scapula and see if one is flaring out, where part of it is flaring out towards you, or are they both absolutely flat against the back? That's what I mean by winging. Look and palpate for joints and muscles. Before I go on, I want to say that winging of the scapula is real common with the cervical 6, 7 injury. And cervical 5 and 6 are real commonly injured in car wrecks with whiplash. So that's why these are some of the ones you're going to have to know more often than others. Muscle strength of a newborn. You realize this is a newborn about a day old, and you realize that they can kind of put their legs down, but not really. They're not able to support their head all the way. They don't know what to do with all these limbs, and they've been out of a tight-fitting space, so they're not sure what to do yet. Shoulders, look at the range of motion, forward flexion, hyperextension, abduction, which is going away from the body, abduction, going towards the body, internal and external rotation, shrugging the shoulders, and I'm about to show you all pictures of that. And so here's ways to do, looking at picture C, you're going to do internal rotation, and D is external rotation of the shoulders. And then shrugging the shoulders is one that you got to know, because this tests your trapezius muscle, and that is your 11th cranial nerve. That tends to be on exams. So remember that. Okay. And you want to look at the supraspinatus muscle, abduct the arms 90 degrees and flex the shoulders forward 30 degrees. Apply downward pressure on the distal humerus when the arms are rotated so that the thumbs point down or up, and see if there's any kind of pain there. Another way to test this, they call it the Coke can method or beer can method, where you put both arms out and you want to rotate like you're emptying the beer cans, and then you want to rotate up and see if that's any kind of pain as you look at the rotator cuff muscles. I'm also going to talk to you about Hawkins test and show you a picture of that. And Hawkins test is a little bit more aggressive way to look at the rotator cuffs and to see if there's any kind of impingement or rotator cuff inflammation. Okay. The suprascapularis is the arm at the side, elbow flex 90 degrees, and rotate arm medially against resistance. And this is the same thing as what the stop sign test is what a lot of people will call it. Look, is it acute or chronic? History, present illness, and past medical history, if there's any previous joint injury, traumas, or surgeries. Common cause of the shoulder pain, acute, less than 2 weeks, fracture, dislocation, separation, subluxation, rotator cuff tear, and a lot of times that would heal on its own if it's less than 50% torn. And biceps tendon rupture for chronic would be arthritis, subacromial bursitis, impingement syndrome, frozen shoulder, or rotator cuff tendon tears. Okay, shoulder pain, complete range of motion is active and passive. Look at specific tests to test rotator cuff. Differential diagnosis, look for any fractures, dislocations, sprains, strains, degenerative joint disease, bursitis, ligament injuries, impingement, or any partial tears or complete tears. So rotator cuff, remember that there's the acronym for that is, remember on the rotator cuff you've got several muscles that are in that area that affect the rotator cuff, and the easy way to remember them is sit, supraspinatus, infraspinatus, teres minor, and subscapularis. Muscles are separated from overlying coronaracroid arch by two bursae, and I showed you a picture of that earlier. So here's the muscles of the rotator cuff that you're looking at and where they're at. So remember, the humeral head is just like this golf ball, and the rest of the body is the tee. And you realize this is from American Academy of Family Practitioners, and it's the evaluation of the pain for shoulder, and I've got a video of that, and I'll let you just look at that, but realize that there should be a lot of mobility in the shoulders. It's much more complex, the shoulder, to rehab than the hips, than the knees, because they move so many different ways. And so what I do is you identify the clavicle, you know where the deltoid is, and where they've got this picture here of the acromion here is where you often find the posterior rotating cuff. And so here it is where you'd find the posterior rotating cuff, and the anterior would be here, because this is obviously the posterior view. Specific shoulder test. Neer's test is a test for impingement. Hawkins is a more subtle impingement. There's, and it's rotator cuff inflammation or tear. You can get Gerber's lift off test, and where it's telling the different types of tears. These are getting really specific. But what I want to tell you is the most common ones that you will need to know is Hawkins, and then the supraspinatus, and that's the empty can test. I called it the beer can test, but it's where you you have your arms straight out from your shoulders, and you want to act like you are with arms extended. If you are rotating a can up, or rotating a can down. And the other thing is when you're doing this drop arm test, and it's because your supraspinatus muscle is the one that's most commonly injured. Like when you have both hands out in front of you and you're doing a Romberg, and you have the patient shut their eyes, this drop arm test, this arm will begin to drift over time if they've got a real problem with the tear in the supraspinatus muscle. The second one that's important for you to remember is the Hawkins test. It will tell if there is an impingement of the rotator cuff, either one, and it's a more aggressive way to look at rotator cuff issues. And it can be inflammation to tear, depending on how bad that inflammation is. So the Hawkins is what I showed in class. It's often a stop sign is what it is, where you have, just like a motorcycle, if you ride a motorcycle or a bike, you hold your hand out, and you're going to have your arm adducted 90 degrees, and your hand will be up or your hand will be down. And so if you have your hand up, you're going to have somebody try to resist you as you push forward or pull back on the arm, and see if that causes pain in the rotator cuff area. Neer's test for impingement. On this one, the arm is straight, and they're going to come back towards you. And you have the thumb pointed down is the key thing here. And there's American Academy of Family Practice video on that also. Hawkins test, forward flexing shoulder to 90 degrees, elbows flexing 90 degrees, and then internally rotating the arm to its limits. And the limits that it can rotate on its own, and the limits it can rotate against resistance. And it's going to, once again, tell you rotator cuff inflammation or tear. Okay. And here's just where you're going to find the rotator. That's where the person is pushing, is going to be the posterior rotator cuff. Okay. And they're identifying the acromion. So anyhow, that's how you'd find it on the shoulder. And the Neer's test is the one on the left, and the arm is extended, and the Hawkins test is the one on the right, and I call it the stop sign test because it's how you indicate stop signs when you're riding a bike or a motorcycle, or if you've ever been in the military, it's how they do the stop, and they make a fist when they have that hand up. On this one, this patient is pushing against the preceptor or the APN, and he's going up against her to see what kind of resistance he's able to tolerate on the picture on the right. Specific shoulder test, separation is if you do a crossover test and you're going to cross over. You got pictures of this in the book. And this gets really detailed that you don't have to remember all these tests, but you do have to remember the Hawkins, you do have to remember the can test, the empty can test, because rotator cuff is your most common thing. But what I do want to tell you is the other test and what they're really looking for, and so I've listed them here. You've got some good videos of it, so watch the videos that are there. And so you're going to look at the observation and each of the bony structures that you're trying to do. And active range of motion, and so you've got this range of motion in the shoulder, abduction and abduction, from that is under your assessment of the shoulder, so you can see that there. Okay, range of motion, internal rotation. This is another way to do it, to see how much can they touch on their back, on their range of motion. What you're looking for more than anything is it equal bilaterally? Passive range of motion, if pain with active range of motion, assess the same with passive range of motion and see if you can get 5% more on that range of motion. So here you go. This is how much that they will move, and it's on the video, so I'm going to keep going. Bicep tendons, and you've got your greater and lesser tubercle of the humerus that are listed, and this is just a review of anatomy. And there's this picture down here on the bottom is got a biceps rupture, and I'm in Texas, and here in Texas the most common reason for bicep rupture is they're riding broncs in the rodeo, and it's the arm that they tie to the bronc or the bull in the rodeo, and they pull and they rupture the bicep. Otherwise, you tend not to rupture the bicep without a whole lot of twisting and stress on it. Like if you're trying to get bronked off of something, bucked off of something, really. Okay, and here's the AC joint testing. And you see a picture here. This is a real common one where you've got a dislocated humerus head. And what catches your eye is, see the slope of this shoulder, and then the one on the right seems like your clavicle is just jutting out. You look at the elbow, and this elbow will be significantly lower than the other, and they're not going to move this entire left side. And you've got a slipped humerus head. Okay, for shoulder exams, once again, you want to do range of motion, empty can test, and then resisted and internal and external rotation. Palpate the subacromial palpation, because that's the only way I can find the anterior and posterior rotating cuff. Then you're going to do the Hawkins test. The Neer's test is the thumb up, thumb down. And you got the thumb down and you do the straight arm raise. And those are the ones that you normally are going to do. Okay. TMJ, you're going to palpate for crepitus, protrusion, contractions. It's somebody that you do this and somebody that has headaches, jaw pain, ear pain. And so here you are palpating the temporomandibular joint. Cervical spine, you're going to inspect the head for alignment, symmetry of muscles and skin folds. Palpate the tone, symmetry, tenderness, and spasms. And look at the range of motion, and here's what it is. Assess for muscle strength in the sternocleidomastoid, which is the muscle that connects the neck to the anterior chest, and the trapezius, which is on the back. So here's his sternocleidomastoid, and the trapezius being on the back, and you're going to see how much you can rotate. Here's the normal. And then you're going to do that against resistance, and here he's pushing wherever she touches him on his head. Spinal processes, you're going to see the spinal processes and feel them, feel all the way down the spine on both sides of the spine for any kind of point tenderness, and then you're going to feel the spinous processes or the bony part of the spine and palpate down with your thumb all the way down. Okay, thoracic and lumbar spine, look for alignment, straightness, curvatures, and you're going to look for lordosis, sway back, kyphosis, hump back, and scoliosis is having an S on the back. And so here you go. You've got the normal spine and the posterior, oh, that's the anterior view, and the side lateral view is you're seeing the normal curvature of the spine to the far left. And picture B is kyphosis, C is lordosis, and you see where the stomach looks protruding, the pelvis is tilted forward, and gibbous is in D, and it's just like a V on the back, all the way. Osteoporosis, or doe-wagger hump, that's the British term for old ladies hump. But that happens with osteoporosis. You have thoracic and lumbar spine. You want to palpate them for tenderness, range of motion, and, oops, I'm sorry, I went the wrong way. And so here you are palpating the spinal processes of the vertebrae. And here you're doing the rotation and flexion of the waist. Lower spine assessment, you're going to do the straight leg test. And the straight leg test for lumbar root irritation of L4 to S1, or the L5 area, you know, give or take one vertebrae. And so that's important to remember, because this is L5 is a real common area to have problems with. And so this will tell new nerve root irritation for L4, L5, and S1. And but L5, L4, L5 is where you have so many lumbar issues on people with pendulous abdomens. And what you do is you have the patient lie supine and the neck slightly flexed. Lie on their back. Slightly flexed neck. Ask the patient to raise a leg, keeping the knee extended or straight. And there should no pain be felt below the knee with leg raising. And if you got reticular pain below the knee in a dermatome pattern, it may be associated with disc herniation. And S1 is going to be on the back of your Achilles. L5 is going to be on the front of your gastrocnemius area of your thigh. I'm sorry, not your thigh, your calf. Femoral stretch, it's going to tell nerve root irritation of L1, 2, 3, and sometimes L4. Have the patient lie prone and extend the hip and see if any pain occurs. No pain should normally occur. The presence of pain on extension is a positive sign of nerve root irritation at the L1, 2, and 3. This time they're lying prone and they extend the hip. So they got to lie on their stomach. Hips, just general anatomy, so you remember the hips. Okay, inspect symmetry, size, gluteal folds. You want to palpate for stability and tenderness. Hips, you want to assess how much they can move, and I'm going to show you the normal movements. Look at the landmarks, and then you're going to palpate for tenderness, swelling, bogginess, or crepitus. So that means you got to say swelling, tenderness, bogginess, or crepitus, and if you feel any of that when you're palpating for your check-off exam. Legs and knees, just telling you, you should normally flex the knees 130 degrees extension. Expect 30 degrees of full extension, hyperextension, 15 degrees or less. And assess muscle strength bilaterally. So on this is showing you hip flexion. And you're going to see this is, bottom right is Trendelenburg on a little toddler, and what you're doing is you're looking at the iliac crest, and you're going to have them raise one leg and then the other and see if one hip drops or not, and that's going to let you know you've got subluxation of the hip on the side that drops. This picture on the bottom left is where they're lying prone and they're hyperextending the leg to see if they've got any lumbar irritation in L1, 2, 3, and sometimes 4. Okay, this picture in the upper left is they're flexing the hip and they're seeing if there's any pain with flexion of the hip. And the upper right is they're doing the straight leg test and seeing if there's any pain with flexion of that leg, and that would be L5, S1. Okay, the gait, you're going to look for stance and swing, palpation of the greater trochlear, ischial tuberosity, sciatic nerve, range of motion. Special testing is Trendelenburg, Thompson test, and Ober test. Those are not ones you need to remember much besides the Trendelenburg test. And Trendelenburg test is this bottom right one on kids where you hold up one hip and see if the leg kind of slips down, and that's going to let you know you've got a slipping femoral head on the side that slips, okay? On somebody that's having hip pain on children. All right, realize the hip is deeply embedded in the pelvis, known for strength, ball and socket, and it's got 5 powerful groups of muscle to move it, and there's your groups. The Thomas test is to detect flexion contractures of the hip, and it's masked by excessive lumbar lordosis. Have the patient lie supine. Full extend one leg flat on the examining table and flex the other leg with the knee to the chest. Observe the patient's ability to keep the extended leg flat on the examining table and lift the extended leg off the examining table, indicating a hip flexion contraction. And so here's that hip flexion contraction on the Thomas test. The point is, it's not the leg you're flexing. You want to watch the other leg to see if it kind of cheats by beginning to flex up off the table. That's what's going to be a positive Thomas test. Trendelenburg test, and I've already shown this one. Limb movement performed when there's difference is suspected. You want to measure bilateral circumference and length of the legs. Should be no more than 1 centimeter difference in length and circumference between matching extremities. There's going to be a little difference in extremities, and nothing's going to be done about 1 centimeter. But any more than that, they might put a lift in one of the shoes of the shorter leg. They're not going to do a whole lot about differences in arm extremities. Here's another way to measure the Allen test. And this is looking at the femur length. You put a baby on the back, raise both knees up, get your eye at eye level, at the level of the knees rather, and see if one femur is longer than the other. You can see this baby on the upper right is going to have a lift in his right leg on the shoe, or else it's going to have permanent problems with the hip in the back. The other thing is, you see that This is the same baby standing up and that you see on the left, and you see on his right leg, or her right leg, there's more gluteal folds on the right side than on the left, both anteriorly and posteriorly. That's a clue. That leg is the one that needs the lift because it's shorter. Okay. This picture to the right is called Allen, A-L-L-E-N sign. And let me back up. It's called the Alice sign, A-L-L-I-S sign, not Allen, Alice sign. And you see on this infant, this boy's got his left femur is shorter than his right. And infants, you're going to look at the posture, spontaneous generalization movements, inspect the back for hair tufts and dimples, discoloration, cysts or masses near the spine, and curvatures of the spine. And the infants are going to inspect extremity, symmetry, movement, equality, deformities, palpate the bones for fractures or dislocations, crepitus, masses, and tenderness. And looking at the knee, realize it's the largest joint in the body. It takes a lot of blows. So you got three major things you got to look at: the femur, patella, and tibia. You got what strengthens the knee is your quadriceps and hamstrings, and on the bottom, the gastrocnemius. And like I said before, your medial cruciate ligament, lateral cruciate ligament, ACL, and PCL, all of these are going to be whatever mechanism you get hit by, it's the opposite side of the knee that takes the brunt of the blow. And so if you get hit in the back, it's your anterior cruciate ligament that gets hurt. You want to look at strain and sprain, and you realize that a strain is stretching injury to the muscle. A sprain is a stretching or disruption of ligaments. There's first, second, and third degree. And so look at the knee anatomy. And so this just gives you a picture to know where the knee is. And not where the knee is, but where the bones are of the knee, rather. And you want to see if there's any kind of painful walking, any scars or past surgery. Range of motion, you can do active and then passive. And you're going to assess for a large effusion by doing ballottement. And on ballottement, you're going to push on one side of the knee and see if a wave of fluid goes to the other side of the knee. And the meniscus is the normal functioning anatomy of the knee. And this picture has got a good picture of an artificial meniscus. You've got the medial and the lateral, and this is the only thing that keeps the bone from wearing on bone. And so to test the meniscus, you can do the McMurray test, or you can do the Apley's test. And to test for torn meniscus. All right. So this is looking at medial lateral meniscal tears. And so you're seeing that these are lines that were surgical lines. And you've got a video on meniscal injuries. Knee assessment, ballottement, looking for excessive fluid or effusement. Bulge sign is excessive fluid. McMurray test is a torn medial or lateral meniscus. And this is important to remember. The patient lies supine and flexes one knee, and there's a palpable or audible click, pain or grinding or lack of extension outward and inward valgus during flexion of the knee is a positive sign. So here you're testing for ballottement right below the patella. Push on it and see if you can feel with your other hand any kind of fluid wave. And here's another bulge sign where you're pushing on one side and you're looking at the medial side to see if there's fluid coming. And this is the way that you look for the McMurray test. The knee is flexed after the lower leg is rotated to the medial position. See how she's rotating he is rotating the lower leg to the medial position or inward position, and seeing if there's any kind of pain with that. And so you've got a video of this. Is an easy way to look at the McMurray sign on the medial meniscus. And here you go on the lateral meniscus, how you would do that. And you've got a video of this. All right. Now on this one, this is the Apley test. And pushing downward, you're going to put your hand over the calcaneus, and pushing downward is what's going to cause pain on the knee, and particularly the menisci. And so you rotate the foot inward for the medial meniscus and outward, the toes outward. So you rotate the toes inward for the medial meniscus and outward for the lateral meniscus. Okay, the ligaments, 4 bands that connect the tissue and the 2 bones. You need all 4 to be able to move this knee. So looking at the medial cruciate ligament, what you're trying to do is you're trying to change the direction of the force between the tibia and fibula on the bottom and the femur on the top. And how you want to do that, how you know which way you're doing is follow the hand on the top over the thigh. Which way are your fingers pointing? Are they medial or lateral? And that's how you know which way you're testing. Okay, on the lateral, notice that his fingers are pointed laterally on the upper hand. Okay, another way of testing for the MCL or ACL is to have the leg straight, and you're going to cradle it in your arm, and you're going to try to twist the knee to see if it will give on either side. Doing it this way, and if they've got a real tender knee, you will get there quickly. Meaning that if you go ahead and give some medial stress, you will immediately, if they've got a bad ligament, it's going to cause pain. So you don't have to be real aggressive with this kind of assessment if you're going to do it cradled like this gentleman has got pictured. Anterior and posterior drawer are instability of cruciate ligaments, the anterior and posterior. And you're going to see if there's any change between the right knee and the left knee. And this is the anterior drawer. This only works if you're sitting on the foot or doing something to stabilize the ankle. Okay, and you're going to pull anteriorly for the anterior drawer and push posteriorly for the posterior drawer. Okay, in PCL, you're pushing on it. And the Lachman's test has the anterior cruciate ligament integrity. And then the Vargas and valgus stress is instability of lateral medial collateral ligaments. Okay, the Lachman test is anterior cruciate ligament, and the valgus and vargas stress test is instability of the lateral and medial collateral ligaments. And so here is your knee exam one more time, and you've got videos of this. And here's how you can do the Lachman's test with patients with big legs or examiners with small hands. And how I do it is I tend to do like, I'm going back up to this gentleman, where I'll put the ankle underneath my arm, and it's easier for me to grab a larger leg patient that way. Okay? And with this, you're going to have the leg off the table. You're going to put the ankle between the legs and stabilize it, and then place a hand on the femur, and you're going to go opposite directions. And on this picture, they're testing the medial cruciate ligament because that's where which way the fingers are pointing, that's over the quadriceps. Okay, Valgus stress test. Same thing is where you're gonna do valgus stress, and remember that when you do this, you're gonna have the leg extended. Okay, anterior knee pain assessment for patellofemoral problems. And on the anterior knee pain, you're going to have it with the knee slightly flexed. Push down the patella, see if it hurts. Okay, so here's your summary of maneuvers and what they mean. Feet and ankles. Feet and ankles, here's your anatomy of the foot. And you're going to inspect and look at the contour and position, size and number of toes, how their alignment is and what kind of weight bearing it is. You're going to palpate for heat and swelling and tenderness. And so you see here that there's pronation of the heels, and weight bearing is not through the midline of the foot. It's more towards the medial aspect of the ankles. So you want to see if there's any dorsiflexion or plantar flexion, and if they're able to dorsiflex and plantar flex. And plantar flex is where you point your toes down, dorsiflex where you point your toes up. Inversion is where you point the sole of your foot in. Eversion is where you point the sole of your foot out towards, away from your body. Abduction and adduction, you're adding it to the body. That's the same. Adduction of the ankle is the same thing as inversion. Abduction is the same thing as eversion when you're looking only at the sole of the foot, not at the toes or anything else. You're looking at the sole of the foot here. Assess the muscle strength bilaterally. And then a couple of common abnormalities in the musculoskeletal system is carpal tunnel syndrome. Realize that you're going to tap on the median nerve to figure this out, and that is called Toone sign. Or you can do the feline sign, which is that inverted prayer, and you're going to test it for a minute and see if you have numbness or tingling. Gout is a common painful purine metabolism that results in elevated serum uric acid levels. It's a form of arthritis. Lyme disease is a tick-borne disease that can lead to multi-system infections. TMJ syndrome is a painful jaw movement. Osteomyelitis is infection of the bone. Bursitis is inflammation of the bursa. Paget's disease is a focal metabolic disorder of a bone. Fibromyalgia, it's got rapid, painful transit pathways where there's painful, non-arterial conditions that lead to diffuse musculoskeletal discomfort. Osteoarthritis is deterioration of the articular cartilage covering the ends of the bone and synovial joints. Rheumatoid arthritis is chronic systematic inflammatory disorders of the synovial tissue surrounding the joints. Realize that sports injuries, you got muscle strain, can be due to excessive stretching or forceful contractions beyond the muscle functional capacity. Dislocation is complete separation of the contact between two bones of a joint. Fracture is partial or complete break in the continuity of a bone. You can get tenosynovitis or tendonitis as inflammation of the tendon or the sheath around the tendon. A rotator cuff tear or micro tears. The rotator cuff is often in the supraspinatus, and that's why I kept stressing just to do the Hawkins test is one of the most common ones, and then the empty can test. Infants and kids, they can be club-footed, that can be fixed. See if they can get past that in 14 months or fix it. Metatarsus abductus, most common congenital foot deformity. And realize that on any of these that look severe, you're going to refer them to orthopedics. Metatarsus abductus can be either fixed or flexible. And leg-calf Parrott's disease. And that's a vascular necrosis of the femoral head. That's real important to remember. And the big thing about Leg-Calvert's disease is that if you have hip pain that's acute or chronic, you have to be very careful to make sure that they don't have Leg-Calvert's disease and have a vascular necrosis of the femoral head. It's not that common, but it's something you cannot miss. Okay, club-footed. You can have Osgood-Schlatter's disease, which is real common. And what it is traction apophytosis, and inflammation of the bony growth of the anterior aspect of the tibial tubercle. And what you want to do on this is right below the knee, on the bone that you feel right below the knee. It's really tender. These people tend to be people that kneel a lot, gymnasts, baseball catchers. The treatment of this is going to be some NSAIDs and rest. 2 weeks of rest or 3 weeks of rest. And to a gymnast, that's going to seem like an eternity, but rest is what's going to help this more than anything. The other person that gets Osgood-Schlatter's disease is people that do tiling and flooring, they're on their knees a lot, that kind of stuff. And they're just got real tender on the tibial tubercle, which is the bone right, it's the tibia, but that big knot that's underneath the knee that sticks out is real tender. All you got to do is stay off it. And a couple of weeks, and that will make a world of difference. You can have slit femoral epithesis, and this disorder of the capital femoral epithesis slips over the neck of the femur. And you see that whenever you do the Trendelenburg test. You can have muscular dystrophy as a group of genetic disorders, and it has a gradual deterioration of the muscle fibers. Scoliosis is concave curvature of the anterior vertebral bodies. And then radial head subluxation. It's better known as nursemaid's elbow. It's a dislocation injury, and I mentioned that this is common for the most common ways when you pick a kid up with only one arm. And you try to get them to get in the car, you can dislocate the elbow. Scoliosis. Older adults, osteoporosis is very common, decreased density of the bone. And then you can have the Dupuytren's contractures at the flexing tendons, and here it is, where the flexing tendons are always contracted. Okay, what they do with that is they inject a little Botox sometimes to loosen that tendon up. Osteoarthritis is degenerative joint disease, non-inflammatory, and it causes the loss of articular cartilage. Okay, it's the absence of synovial membranes, lack of systemic signs. You have normal synovial fluid, but you don't have the membranes. It occurs in later than 40 years old, associated with joint stress, congenital abnormalities, joint instability, diabetic neuropathy, inflammation of the joint. Is it autoimmune? They don't really know. And results of ossification and deformity of the joint and erosions of the cartilage with some spurs. So osteoarthritis, see, this would be a normal joint on your left, and on the right, this would be an osteoarthritis, and gradually it will tear down all the way to the bone level. Common places are in the neck, lumbar vertebrae, hip, hand, knee, and foot. It tends to be on one side of the body more than both. It at least starts on one side of the body. It might progress to both later on in life. And you realize that you got Herbrand's nodules and Bouchard's nodules. And I want to just clarify, just in case I said this was rheumatic arthritis, it's really osteo. Osteoarthritis is where you get the Herbrand's nodules and Bouchard's nodules. I think I said osteo, but I don't remember. Just want to clarify that. Pain, worse with weight bearing or use of a joint, relieved by rest. That's important to remember. Not all nocturnal pain relieved and can refer to other parts of the body, especially if in the spine. They have joint stiffness decreased with movements within 30 minutes. Range of motion limited due to the osteophytes. Treatment is weight reduction, glucosamine, chondroitin, walk or run, range of motion exercises, and NSAIDs. Rheumatoid arthritis is an inflammatory joint disease, so it works with anti-inflammatories, NSAIDs, aspirin, that kind of stuff. It's autoimmune. It causes chronic inflammation of connective tissue, affects the synovial membranes, and eventually inflames. Inflammation spreads to articular cartilage, fibrous joint capsules, and surrounding ligaments and tendons, causing pain and loss of function. Okay, and you've got on osteoarthritis, you've got the ulnar drift, and you've got subcutaneous nodules often, but the ulnar drift is real common. All right, thank you very much, and that's musculoskeletal examination.